To start our clinical part of the year in review is going to be Dr. Marleen Kok from the Netherlands Cancer Institute. She is senior group leader in the Department of Tumor Biology and Immunology, and she will talk to us about early breast cancer. Thank you.
Good morning, colleagues and friends, ladies and gentlemen. First of all, it's very special to stand here from a small country in the Netherlands. I think I'm the first Dutch person standing here having this lecture, so it feels very special to me. Early breast cancer. Let's see what we have seen in 2022. I have disclosures, and of course I have a disclaimer. Your favorite highlight of the year might not be in my presentation. I will only present snapshots. And what is a snapshot? It is considered technically imperfect, amateurish, out of focus, and poorly framed. So that's basically my presentation. Of course, you will see data per subtype. I would like to give special attention to lobular, quality of life, and local regional treatment, which is a challenge for a medical oncologist to review all those brilliant papers from the surgical colleagues. Why are we on Earth? As Dr. Kent Osborne explained, the ball. What is the essential? Why are we here? To cure disease, minimize toxicity, preserve long-term quality of life, and fourth, financial considerations. More and more we have to realize that we can spend $1 once. Triple-negative breast cancer. It's the last day of the meeting. You're probably all tired, saturated, so I try to give you a bit of spice. So every subtype will have a painting. And it's illustrating what's happening in the disease, at least to me, or where the field stands. And this painting perfectly illustrates triple-negative breast cancer. And it comes with a poem, and the poem has been written by one of our colleagues, Kevin Puny from Belgium. And the poem states that this is a woman without identity, because there are three things missing, like in triple-negative breast cancer. No eyes, no nose, so no mouth. And it's a request from, let's say, a breast cancer patient to give identity and to better understand what's happening here. And I really hope that the definition triple-negative breast cancer, when I retire, it's not existing anymore. Let's go to the data of this year. I think a lot of the data that come out, we have to put into perspective to the Keynote 522 data. So let's start reviewing that study. Of course, many of you know the data, but just in case you're not working at it on a daily basis, Keynote 522, a landmark study, comparing neoadjuvant chemotherapy to neoadjuvant chemotherapy plus the additional value of pembrolizumab in this case, in the neoadjuvant part, but also in the adjuvant part. We've seen data before on the increase in PCR. First publication showed an increase in PCR of about 14%. Well, if you look at later analysis, for example, in the FDA report, the PCR difference is about 7%. But I will show you later that the PCR, when you talk about immune therapy, might not be the ideal surrogate endpoint. We've seen event-free survival data with a benefit at 3 years of about 7 to 8%, and the follow-up is really mature. So based on this, in most countries, now pembrolizumab is reimbursed, which is great for our patients. But now that this is the standard of care, we really have to look at the quality of life data. And at ESMO, Rebecca Dent presented the data of quality of life in the adjuvant phase of the Keynote 522. Important data. And basically you see tiny differences, whether patients were on placebo or on pembrolizumab. So no tremendous effect on quality of life. But you have to realize that the comparison was baseline adjuvant. So patients come off chemotherapy, and we all know that when you come off chemotherapy after surgery, that they still, suffer from fatigue and all kinds of symptoms. So maybe this is not the ideal comparison, because you have to compare to before diagnosis, because that's their normal life. And that was actually done in a comparator study, the Impassion 131, with atezolizumab plus chemotherapy. Here they compared with baseline. I think this is much better. And here you see the curve for fatigue. And because in this paper they basically also show that adding atezolizumab didn't harm our patients tremendously, but there might be a difference in fatigue. So here if you look at the curves, baseline, patients put on chemotherapy, so fatigue, of course, it's bothering our patients. Surgery, patients recover, but the patients in blue are the ones on atezo, and the red are the ones off treatment, because it's not placebo in this phase. So are we looking here at fatigue because they have to come to the hospital, or is it fatigue introduced, due to the checkpoint inhibitor? It's an important question, and we have to realize that it might affect our patients if we give adjuvant checkpoint inhibition. Then to other data related, coming from the keynote 522 on residual cancer burden. First, I would like to show a paper that also came out this year in Lancet Oncology, led by Christina Yao, showing the data in a large cohort on RCB. So in dark blue, you see the patients having a PCR, in red, the patients with RCB1, RCB2, and in light blue, the patients with RCB3. And I was thinking maybe this is because, there were data from the 90s, but there's also recent data in here. And then if you focus on the light blue curve and then look at RCB3 in the keynote 522, that's still of today. There are patients on treatment, and if they don't have a response, their outcome is very poor. So here, this needs attention. So what was the message of this presentation from Laios Pustra at ASCO? That there is a difference in outcome depending on your RCB status. So this patient section with a PCR, there didn't seem to be a significant difference whether patients were treated with chemotherapy or chemotherapy plus pembrolizumab, basically suggesting that there is a group of patients that you can cure with chemotherapy and they don't need checkpoint blockade. RCB1, similar story, and here you see that the curves separate for RCB2. And it's tempting to think, and we also are trained, if you see a Kaplan-Meier curve like this, that this effect is driven by treatment given in this period. But that might not be the case, because the treatment of those curves was different before. And I think it's very important to realize that the patients in green are different patients. Because they had been treated with checkpoint blockade before, their residual disease is probably different, with more immune infiltrate, or the residual disease is different. There you have immune control, and that can drive this effect. So don't interpret this as the adjuvant effect of pembrolizumab. Other important questions coming out of keynote 522 are the treatments that are not given in that trial, for all kinds of good reasons. Because, in that time frame, that was not standard of care. But we've seen at ESMO data from the GYM2, a large Italian study, with questions that were relevant years ago, but now get long-term follow-up. Is dose dense important? Yes, it is of critical importance for triple-negative breast cancer patients. So you can see in their paper for triple-negative breast cancer, the overall survival benefit is 12%. And that is not given in keynote 522. Important to realize, and please realize that you have to consider also in keynote 522, if you give it to your patients, that treatment should be given dose dense. Adjuvant capecitabine, similar story, long-term follow-up, overall survival benefit of 10%. So it's important in those patients that don't have a PCR coming off of the keynote 522 regimen to treat with capecitabine. The Germans did a very elegant meta-analysis of 13 RCTs, all addressing the capecitabine questions. And here also they summarize overall survival data for triple-negative breast cancer patients that is significant in, in this meta-analysis of trials testing capecitabine as additive chemotherapy. Last but not least, olaparib. There's also been an update on the Olympia study, with now an overall survival benefit of 4% in triple-negative breast cancer patients with a germline mutation in BRCA1 and 2. So you see that treatments that haven't been given show overall survival benefit, and that's important in how you treat your triple-negative breast cancer patients as of today. Another question, coming back to this adjuvant part, what is the added value of adjuvant pembrolizumab if you've already been treating your patients in the neoadjuvant phase? If you look at other tumor types, melanoma, lung cancer, there's no evidence that if you have been treating for 5 or 6 months, that another 6 months or so is helpful. Also, if you look at the mechanism of action, you want to have an immune response. The immune response is kind of a black or white phenomenon. It's happening or it's happening not, or maybe not at all. But it's not if you treat longer that you have a more chance of inducing such an immune response. So it's important to look also at other trials where the checkpoint blockade was only given in the neoadjuvant phase. So Kepar Nuevo with durvalumab given in the neoadjuvant phase together with the chemotherapy. In the light pink, you see the patients with a PCR that were treated with durva, and they have excellent outcome, only durva in the neoadjuvant phase. Also, what this paper shows you is that PCR, that the benefit of checkpoint blockade is not depending on PCR. But even if you don't have a PCR, you can benefit if you look at the EFS data. So that's also reflected by the curve in dark pink. So those patients that didn't have a PCR, but they still were treated with durva, they do much better. Another interesting trial, patients were treated with anthracycline-free chemotherapy and pembro. It's the NeoPAC study presented at ASCO. And excellent outcomes if you reach a PCR without anthracyclines and also without adjuvant anti-PD-1. So we're all looking forward to the NeoTrip data. We've seen PCR data, but the primary endpoint is event-free survival, and also there no adjuvant checkpoint inhibition was given. Other questions, who benefits? And I think it was a perfect introduction by the excellent previous speaker, explaining to you that we've done so much research and there's still no biomarker. And I think now that we give 4 chemos and pembro, we still have to, it's important to look for biomarkers. We've seen data on PD-L1. PD-L1 in the early setting TNBC is not discriminating. But what about TILs? The TILs have been scored in the Keynote 522 study. So I hope to see data next year, because maybe there are answers on who needs pembrolizumab and who doesn't need it. Who benefits from chemotherapy without IO? Still important question to save costs, to save toxicity. And indeed, more than 25 years of research, and we don't have a biomarker in the clinic yet. And of course, this year we've seen bits and pieces on it. For example, the Lehman subtypes. And you see if you have a basal like 1 or 2, your PCR rate in dark blue is higher. But such a marker will be very difficult to implement in the clinic. Because you need, if you want to say, okay, you're not going to respond, you have to be pretty sure, right? Because there's not really an alternative drug. So this needs optimization. You can also put it the other way around. Are there patients that can benefit from IO without chemotherapy? And that question we are exploring in the Bellini trial, and we've presented some data at ESMO. So 4 weeks of immunotherapy and seeing what kind of patients respond. And you see here in the waterfall plot MRI. So if you do an MRI after 4 weeks of immunotherapy alone, you see that patients already have a partial response and also a molecular response. So we've seen ctDNA clearance after 4 weeks of IO. So this concept needs further exploration, of course, but it might be the case that some of our triple-negative breast cancer patients can forgo chemotherapy and can be treated with IO alone. If you take that a step further, is there a group of patients that doesn't need treatment at all? And we've been talking about TILs, tumor-infiltrating lymphocytes. And of course, we know there are a lot of data that TILs are predictive for response to chemotherapy. We still don't use them in the clinic, though. And that TILs are prognostic. But it was an open question. Is it prognostic in the context of chemotherapy? Or is it also prognostic if you look at natural history of disease? Yes, in this set coming from the Netherlands, young women below 40, they haven't been treated with chemotherapy. And not because they were stubborn or the physician was not well informed, not biased, but we took samples from the 80s and the 90s. And because that was not the standard of care at that time. And you see that the women with TILs above 75% or higher, and that is in young women, 20% of your patients, that the outcome was excellent. At 15 years follow-up, only 2% of the women suffered from distant metastasis. And envision that in green, those women, now we treat with 4 chemos and checkpoint blockade. Well, if you do nothing, yes, we do surgery, which is not nothing, and radiation, they might be cured as well. So this also needs further study. Also interesting, if you think about de-escalating your chemotherapy a bit, or a lot, we can learn probably from HER2 positive. It was an aggressive disease, biologicals became better and better, and now we can treat without anthracyclines. Would that be possible for triple-negative breast cancer as well? So this year there were bits and pieces suggesting that that could be. So this is a paper with a pooled analysis from Plan B and Success, comparing trials where anthracyclines were given or not, and showing per subtype whether there was a benefit. And at least this study suggests that there is little or maybe no benefit if you compare all those trials together on the anthracycline question. Also, the West German study group, the ADEPT trial for triple-negative, treated patients with only 12 weeks of taxane-based chemotherapy, no anthracycline. And many patients had a PCR. And then they studied whether if you give in the PCR group additional anthracyclines, whether that was beneficial. But they didn't see an additive effect, suggesting that there is a group of patients for which you don't have to treat with anthracycline. Also, this was illustrated by the trial list from the Neopact. Also, IO plus anthracycline-free chemotherapy. You see excellent outcome for your PCR patients. I think most important, we can de-escalate for the good ones, but what are the patients that don't benefit at all from chemotherapy and IO? And now what we do, we treat for half a year, and then we know, oh, you didn't benefit, and then we come up with something else. I think that's not really elegant medicine. We should be able to predict it upfront. Upfront have a biomarker you're not going to predict, you're not going to respond, and do upfront something else. Because you cannot build further, in my opinion, on 4 chemos and IO. You have to stratify upfront. For example, treat with an antibody drug conjugate first. And that was explored in the NeoStar study presented at ASCO. So 12 weeks of sacituzumab govitecan, and they showed that 30% of the patients had a PCR. And of course, relatively low, but if you're able to discriminate those patients, then hopefully those patients are the ones not benefiting from another regimen. So looking forward to more data on this concept. Then switching gears to HER2 positive. And I promised you to give a painting to give some spice to my talk. And this painting to me illustrates the treatment setting of HER2 positive disease. The bar is high because we do so well if you consider all patients together. So that's also that maybe there was some disappointing news for the HER2 positive early breast cancer space. So this is the design of the IMPassion 050 study, addressing the question whether atezolizumab could add on top of standard of care for early high-risk HER2 positive breast cancer. The trial didn't reach accrual because right before they reached accrual, the IDMC recommended stopping the trial because they saw a lot of too much toxicity in the atezolizumab arm. But if you look at the type of toxicity, 2 fatal cases of COVID, 2 cases of sepsis. So was this really related to the checkpoint blockade or was it bad luck? I think that's an important open question. They present the data on PCR, and here you see that if you add atezolizumab on top of your regular chemo and anti-HER2 treatment, it didn't result in a better PCR. But you have to remind that the PCR might not be a good endpoint. So I think it's important to see the EFS data here. Another update, we've seen overall survival data of the pivotal affinity trial. So the trial, adjuvant trial, addressing the question whether pertuzumab adds. With a follow-up of a little bit more than 8 years, you see that there is not a significant benefit of pertuzumab. Though if you zoom into the really high-risk patients, so the node-positive patients, there is a statistical significant benefit. But the curves are very close. So here, yes, there is a benefit, but is this of clinical significance? And what patient will benefit from this, this antibody? It doesn't come with a lot of toxicity, but still it's extra treatment. We've seen this year also updates from the Caitlin study, an adjuvant study, basically addressing the question, can we replace trastuzumab and paclitaxel by TDM1 in the adjuvant phase? Also in this case, it doesn't seem to be the case that an antibody drug conjugate can really replace a chemo plus trastuzumab. Then going back a bit further on the chemotherapy-free regimens. So this is also from the ADAPT HER2 ER-negative trial. Patients were treated neoadjuvant with trastuzumab and pertuzumab, or a cohort, trastuzumab, pertuzumab, and paclitaxel. And some of them in the adjuvant setting, again, were treated with anthracyclines. And the outcome was excellent, with a follow-up of 60 months. Though I think it's more interesting to look at how this relates to the adjuvant treatment. So here are the PCR rates. So biologicals only, a PCR of 34%, which, might not be that high. But if you add paclitaxel, it's going up to 90%. And then in the paper they present what happened in those patients that were not treated with adjuvant chemotherapy. And they showed that in some of the patients the outcome was excellent. So this is a motivation to further study chemo de-escalation in HER2 positive patients. So now that the outcome of the disease, as shown by my painting, is in general so good, I think we have to realize certain elements. I think we have to learn lessons from trastuzumab and the duration of 1 year. because it was standard. And then we tried to de-escalate to 6 months. But it was so difficult. Many non-inferiority studies, meta-analysis, but still most patients are on 1 year of treatment. And, you know, there are big pipelines of companies. So why this 1 year? It's difficult to get rid of this 1 year. I think it's important to realize. Because now we're still facing the question, who needs pertuzumab for 1 year? And please, if you think about de-escalating chemotherapy, I don't think that the ADC can replace chemotherapy in terms of costs and also toxicity. Also important, you know, I don't know about you, but in the tumor board, if we don't have a PCR, we can like a reflex, oh, we need more treatment. But I think it's also too important to find those good guys among the bad guys. So if you have a non-PCR, but even that doesn't matter, then you're good to go. I think that's an important question for this disease, which is a good outcome. ER-positive breast cancer. This painting is called mixed bag. And to me, I think, of course, there's heterogeneity in triple negative, but I think the most heterogeneity is seen in ER-positive, such a large patient group. So straightforward data that we've seen this year, but very important. An overview from the early breast cancer trialist group, comparing aromatase inhibitors with tamoxifen in our young patients. And they basically show what we already know, that if you treat them with aromatase inhibitors, that you see a benefit in terms of all recurrences, distant metastasis. But if you then look at overall survival, the benefit is getting smaller and smaller. And of course, it really depends on the baseline risk, whether you treat with an aromatase inhibitor or not in most of our young women. Data on ovarian function suppression presented at ASCO, also confirming that in the pre-premenopausal setting, that if you add ovarian function suppression, that your disease-free survival is increasing. Basically also shown and confirmed by the data of the German group in the ADEPT and the ADEPT cycle trial on a different way. So this is neoadjuvant and the effect of ovarian function suppression. So in the bit older ADEPT trial, the tamoxifen was given a single agent, but in the recent trials, in orange, they give tamoxifen plus ovarian function suppression. And if you compare it with tamoxifen alone, it's a huge difference. If you look in this case, a drop in Ki-67, and a drop in Ki-67 relates to outcome. So it's also important if you treat preoperatively to add your ovarian function suppression. I would like to draw your attention to a poster presented at ASCO by Anne Partridge. They were measuring estradiol levels. And they show in the poster that more than half of the patients were not fully suppressed. It was not related to outcome in this data set, but it might have consequences, and it could provide hints that we need other ways of suppressing the estradiol metabolism in our young women. Then a paper on the MammaPrint ultra low risk, because it might be able to, in this mixed bag of patients, to further separate it. Of course, the MammaPrint was classically developed to give you two results, like good signature or poor signature. But now within this low-risk group, there is another group of ultra-low risk. And we have seen data from the Stockholm trial, where patients were treated with 2 years of tamoxifen or no endocrine treatment, that patients with ultra-low risk did very well, even without treatment. But this year we've seen more modern data in the MINDTech trial. You see here that 15% of the patients in the MINDTech trial were genomically ultra-low risk. And their survival, although the curves are very close, was significantly different compared to low risk. Intriguing, if you look at how they've been treated, and I have to remind you that this was not randomized, the outcome is excellent. And there is a blue curve showing those patients that didn't receive treatment, and they did very well. So I hope that you will, we'll focus in the coming years on tools to select those patients that don't need systemic treatment. Then switch gears to our elderly patients. I really would like to congratulate the French group for presenting this data at ASCO on women above 70 years, so the ASTER study. Basically addressing the question in elderly ladies with having a high genomic grade index, whether there was a chemotherapy benefit. And you see in the intention to treat analysis on overall survival that the curves separate in favor of chemotherapy, but it was not statistically significant. 20% of the women or the physicians decided not to give the chemotherapy, despite being randomized to the chemotherapy arm. And if you take those out and look at the per protocol analysis, the effect of the chemotherapy becomes significant. So there is a benefit of chemotherapy in this group. though not very big. So this you have to discuss with your patients, and if they're elderly. And I think this also needs follow-up or a different trial design to learn more for those elderly ladies. So to me, the open questions in the coming years for ER-positive breast cancer, I think, on top of size and lymph node status and grade, we have to subgroup them. Don't do a study for all comers. So take the very young, the young and the elderly and separate them. Even the premenopausal might be quite different from the perimenopausal. And also we have to take into account the endocrine sensitivity based on ER levels or a more fancy assay. And then the different treatment choices that we have, adding ovarian function, duration of endocrine treatment. And also here, if we can predict upfront that the prognosis is very poor, do something else. I would like to introduce a new category for this session because I strongly feel that the lobular is a separate entity. And the painting here, I think the name is very well, it's the unseen. Also here at San Antonio, we've seen posters that it's difficult to detect lobular breast cancer on MRI or patients suffering from metastatic disease. There's a delay here. Also this painting, it's cold, so lobular is a cold tumor. And here you see the Indian files in the scarf of that woman. So I would really like to advocate to also next year have a category lobular within every year in review. So 2022, there are still no specific trials for lobular breast cancer, and that should change. And I know that some trials are ongoing and really hope in the coming years here at San Antonio in the oral sessions, there are data on lobular breast cancer trials. So I will provide some snapshots on important information on lobular because I think it's important to know that there's a lot ongoing there. If you look at how we diagnose, there's been done a survey from the European Lobular Breast Cancer Consortium showing that there's a huge variety in how we are using ECAT herring staining in terms of antibody, interpretation, scoring. The Great Lakes Breast Cancer Consortium showed us that lobular breast cancers tend to have more lymph node positive, larger tumors and a poor survival. How do we treat? So I showed you the data from the Plan B and success on the anthracycline question. It might be the case that lobulars that are node positive, that those are the ones needing anthracyclines. So that's important to realize. A study from Memorial Sloan, they looked at their in-house non-classical ILCs. You have them in your tumor board. Triple negative ILC, HER2 positive, pleomorphic. Sometimes we tend to see, yeah, but it's not a classic lobular, so we might have more chance with chemotherapy. But it doesn't seem the case. Last but not least, the Germans have shown data in the early setting that ERBB2 mutations in lobular breast cancer might be related to endocrine sensitivity. An important finding if you consider antibody-drug conjugates that really can treat patients with an HER2 mutation very well. Other important news, quality of life. I really would like your attention to draw your attention to the canto study. Cancer toxicities, long-term toxicities. And beautiful papers came out this year on toxicities coming from the French group. In this case, quality of life in patients treated with the chemotherapy, 4,000 women. And basically they were able to discriminate 4 groups. So women with an excellent quality of life at baseline, that maintained. Those with a good quality of life, that came back at 4 years. But this group, so they started with a good quality of life, a drop in the first year, they never recovered. It's 10% of your patients. So every day you see a patient probably in this category. We should be able to identify them and to counsel and to help them to get back their quality of life like it was before. Risk factors, young women, ladies that smoke, low income, comorbidities and endocrine treatment. If you zoom into fatigue, because fatigue is I think very important for quality of life, risk factors for severe fatigue, baseline fatigue, and again, young age, obesity, smoking. So this needs a lot of attention because in the end, it's not only curing cancer, but also keep up with your quality of life for individuals. Last but not least, so I attempted to review the literature on all the studies done on local treatment, and of course, most of them was on de-escalation. I think the landmark study, AMAROS, is very important, showing their 10-year follow-up data, basically saying, can you replace axillary lymph node dissection by radiation? Yes, we can. It doesn't harm in terms of overall survival. And now you see more and more papers, making it even more elegant with, for example, using iodine seeds and also taking into account the response to neoadjuvant chemotherapy. And this study shows even in lymph node positive, if you have a PCR, there is a group of patients that you don't have to treat the axilla because they can have a very good outcome. In this regard, I would like to draw your attention to a very good editorial published by Beth Mettendorf in the JCO. Because now with those adjuvant changes for the lymph node positive patients, they felt that there is a tendency to go back to the X-ray lymph node dissection to have more details on how many lymph nodes were involved. But that's not important. So they present to you that if you're thinking about, data from the monarchy, responder trial, etc., that you still have to think of modern ways of treating the axilla. So for me, on de-escalation, the surgeons are the champions, together with the radiation oncologists. And medical oncologists, we should learn from them in risk-taking and selecting patients for de-escalated treatment. Are we there yet? Not yet. Going back to the ball, as explained by Kent Osborne, yes, we cure breast cancer pretty well, but there's still 20% of our patients dying of the disease. Minimize toxicity. We see new treatments coming up. It's giving more and more toxicity. We should indeed also take toxicity into consideration if you think about drug approval. And what about costs? I didn't have time to discuss it, but I think this paper is very interesting. It's comparing drug prices to overall survival. And you would expect that if a drug is very good, that is more expensive, but that's the opposite. So here a call for action for us, academic community, authorities and pharma. I think it's important, also explained by Fabrice André, don't do trials for all comers, but at least do a hybrid trial with a specified subgroup for a biomarker population. Because in the end, I envision trials only for biomarker population. Otherwise, there are too many drugs for too many patients. And to me, value-based pricing is not only efficacy, it's also toxicity. I would like to thank many colleagues for providing ideas, slides, addressing my questions, and thank you all for your attention.